And the decisions we make around transplant, it's constantly a risk-benefit decision, constantly trying to figure out things like if we are to allocate organs based upon age, is that a benefit for some and a risk for other? And ultimately what we're trying to figure out is the net benefit of what is a valuable resource as an organs donated for transplant. And so I'm going to step back a little bit and sort of spend a second just to highlight what I said a few minutes ago. The reason why we make policy and really demonstrated on the website is really to ensure the best possible solutions for patients awaiting transplant and for the donors, whose precious gift makes that possible. You'll see in that definition, it doesn't talk about transplant programs, it doesn't talk about transplant professionals, surgeons, coordinators, it doesn't talk about the organ procurement organizations. It's really all in the cause of ensuring that we're taking care of patients and their needs. The policies and the bylaws, if you're interested, if you're having trouble sleeping, they're all available for you to read. It's very transparent. Folks should know from the beginning how organs are allocated, what the decision-making process is around, I don't know, choose your particular interest, what prioritizes over another. And if you have a question that you want answered, that's the best place to look at it. Recognize that we have limited time to do an enormous amount of work, and everybody that works with the OPTN, we're volunteers. And so the priorities for the organization you can see across the bottom of the slide. And not surprisingly, the number one priority is increase the numbers of transplants. And you can see by the line that 50%, I have a pointer here that I should use, that 50% up there is the amount of time which we say should be devoted to that particular effort, increase the numbers of transplants. Equity, of course, is an important thing we focus a lot of time on, improving wait-listed patient, living donor, and transplant recipient outcomes, and then promoting safety. So that's really where, again, if you think about the work that the OPTN does, where we spend a lot of our time. Allocation is obviously I think the prime thing with which people are most interested in. Each of our organs has a little bit sort of different way right now in which we prioritize how that list is run when our coordinators and when our team sort of pulls up the match run list. And sometimes that can be in the order of 40,000 patients, for instance, of a patient who is a blood type O donor on the kidney match run list. So it is a little bit sometimes difficult to understand. I think we would all probably agree that the goals of any of our allocation system are probably something with resonate with everybody, including in the audience. Make the most of the organ, promote graft survival, minimize loss of graft years, improve the efficiency and utilization of those particular organs, make sure that there's data to both make decisions before and after, and try and reduce differences in access. There really should be, particularly in the United States of America, there should be no reason why anyone has a greater advantage or an opportunity to receive an organ over anyone else. And I'll talk a second about how geography is changing that. If you look at kidney as an example, good example, right? We're at a kidney meeting. Primarily, things are still based upon a point system with allocation categories, and points, the higher the number of points that a recipient receives is really distinguishes where they are on the match run list. A lot of these things you can understand, but you'll recognize that when you still put recipients in categories, it still is difficult to sometimes make sense out of why one individual is higher than another, and I'll show you an example as to why I say that. But what you have to recognize is that allocation changes happen few and far between. I'm going to talk about one that happened a couple years ago, but prior to that, 10 years prior, there was an allocation change with which, there was a number of important things that looked at trying to ensure that the kidneys that had the highest potential for discard were allocated more broadly, trying to match donors and recipients more closely with longevity matching, trying to make sure people that had antibodies were towards the top of the list. And primarily, we still look at dialysis time as a surrogate for severity of illness, and that's, again, where priority happens. But now we've recognized that, again, we need to remove geography from completely anything that has to do with allocation. So regardless of whether you live in Palm Springs or Hackensack, New Jersey, or Colorado, Denver, Colorado, everybody should have an opportunity to receive an organ. And that certainly wasn't the condition when you looked at it prior to this most recent allocation change. In fact, you can look at that quite extensively, and you can understand why, or you can hopefully appreciate that very things down here on the right should have very little to do with how someone is allocated an organ. In the middle, there's a little bit of a challenge because if people have a prior kidney transplant or based upon what their diagnosis and their challenges from a surgical and medical standpoint. But to the left, blood type and sensitization, yes, but where someone lived, the donor service area, was very difficult for anybody to justify as a rationale or as any contributor to determining where an organ should be allocated. And so we currently use a model which is based upon the distance from the donor hospital, Wherever a donor happens, we draw a 250 nautical mile circle. We suddenly all became sailors. We had to learn what nautical miles meant. But essentially it said, if the donor hospital was here in H, if a transplant program fell within 250 nautical miles, centers B and E here, those patients on those lists would have priority because they were, again, in a relatively close area to the donor, and then all those categories which I showed you before took over. And then beyond that, all centers outside of that 250 miles had access to those organs. It's easy to explain. It's something that we can understand is available particularly for urgent patients, but still there's a boundary to that. And it was tough to figure out why 250 nautical miles had anything to do with that. Again, it kind of looks a little bit like this. I always think it's better to look more at a picture. Our previous allocation system had these donor service areas were just for sort of areas of the country. There was 56 of those. Now I think it's 55. It keeps changing daily. And then things would actually be divided into a particular region. There's 11 regions in the United States. And then things would be allocated on a national basis. But what we're doing now is things are based upon that 250 nautical mile circle. And you can appreciate that based upon where that donor hospital is. Sometimes that circle includes a lot of dolphins and fish and marine life. And sometimes there's a very low populace based upon kind of where folks have decided to call their home. And so again, it's still very different in parts of the United States, access to organs and therefore access to transplants. And so we have to continue to think about sort of different ways than just saying everybody who is highly sensitized should be at the top of every waiting list and everybody who is a living donor should be the top of every waiting list, because that, although sounds reasonable, is still perhaps not the best way to allocate organs when you're thinking about over 100,000 people waiting for transplants across the United States. It's worked so far. The 2022 year results are, I think, outstanding. Increases the numbers of transplants, particularly for those that in the past may have not had equal opportunities to organs. There really hasn't been an extensive amount of cold time when we expand the way in which organs are allocated, and the numbers of transplants within that 250-mile circle increased. If you look at it graphically, based upon, again, demographics, age at listing, or again, how long people have been listed, which again was probably the biggest change. So people that were listed for 5 and 6 years and longer, regardless of where the donation happened, that's where the organs were actually heading to. But again, the question was, why 250 miles? Does that really make a difference whatsoever? And so what you're going to hear more and more about is something called continuous distribution, which means regardless of how far patients are from a donor hospital, we're trying to change that so we can think about a framework that's more flexible, more equitable, and allows us to make sort of little tweaks to the system that may help us to optimize the way in which organs are allocated. It's somewhat complex, and if you look at the various pieces of that decision that ultimately result in a composite allocation score, it demands that we look at each of these and decide which is more important than the other, how much more important is one than the other, and a lot of important volunteers and statisticians that are sitting down to try and figure out how to compose that continuous allocation score. These are the variables that we have available to us. Important to appreciate. There's a lot of things that we might think, even as a community, we'd want to add to an allocation scheme, but we don't have all that data. We think it's important we can change that so that we have, again, more additional pieces that we think are relevant. And so ultimately, what you're going to see is a candidate's score is going to be made up of a little bit of everything. And so it's not just one category that puts someone at the top of the list. They may have, again, the best chance of survival after the organ. They may be a blood type with which it's highly competitive to receive an organ. They may have, be really close to the donor hospital. And so adding those all together, we think is going to be important. And then this is what we think the match run is going to look like. We have, again, the desire to make sure that we're looking at this scientifically and making decisions to predict what things are going to turn out before they actually do, so that we're not just sort of guessing that the results are going to be better than they are before. And we can even look at sort of adjusting that model, as I showed you before, for particular groups of kidneys. So if we want to maximize the opportunity for an organ to survive following transplant, we can prioritize those things. If we want to look at ensuring that it's the best shortest amount of time for an organ to get from a donor to recipient, particularly for those marginal organs, we can change the allocation system to look at that.